Hi, everyone. Welcome to our Targeted Therapies Forum 2023. I'm Jessica Lin. I'm a medical oncologist at the Mass General Cancer Center in Boston. And I have the great... Sorry about that. So I have the privilege of co-chairing this forum together with Dr. Sandeep Patel from UCSB, who will be joining us very soon. We're really excited to have you here today with us on a Saturday. So as many of you know, the purpose of this meeting is to get you introduced to a range of topics that we think are highly clinically relevant in lung cancer in the realm of targeted therapies, and hopefully to get many of your questions answered throughout the sessions as well. We have a fantastic lineup of really incredible faculty speakers today. They're coming from new centers and across multiple disciplines. In the morning, just to give you a roadmap for today's conference, we're going to start by reviewing some of the more general key topics. These include biomarker testing, which is the pivotal first step to getting you access to the optimal treatments. And then we'll review the role for targeted therapies in the non-metastatic disease setting. And then treatment options that can be used after targeted therapy or together with targeted therapy. Then we're going to have a brief lunch break, followed by breakout sessions. These are some of our favorite sessions for this conference, where each talk is dedicated to distinct genomic drivers and questions inherent therein. And then in the afternoon, we're going to have another general session where we have our patient research advocacy presentation, which is always a highlight of symptom management and palliative care. So before we go on to the first session, I see Dr. Patel was able to join. So Dr. Patel, would you like to briefly introduce yourself as well?
Absolutely. It's a pleasure to be joining you, Dr. Lin, as well as our wonderful faculty for today's session. I'll look forward really to an enriching session that'll help us better understand how we can best help take care of our patients from both an oncology standpoint, patient advocacy standpoint, and community engagement standpoint. And I'm really looking forward to co-chairing this with you.
Well, thank you. So without further ado, let's go ahead and get started. Our first presentation, we are very happy to have Dr. Akash Desai join us. Dr. Desai is an assistant professor of medicine at the O'Neal Cancer Center, University of Alabama, Birmingham. And he has dedicated research focused on evidence-based oncology, clinical trials, drug development, healthcare delivery, and quality of cancer care, with particular interest in thoracic oncology. He's won numerous recognitions and awards for his work. And this morning, he's here to tell us about the fundamentals and challenges today with biomarker testing in lung cancer. Dr. Desai.
Thank you so much for that kind introduction, Dr. Lin, and thank you to the organizers and our co-chairs for inviting me to speak on this topic. Before I start, can you just confirm for me that you're able to see the slides and hear me clearly?
You should be all set, Dr. Desai.
Perfect. Well, good morning, everyone, or good afternoon, good evening, wherever you are. So I'm going to start off with talking about biomarker testing, the key fundamentals and challenges in biomarker testing. Here are my disclosures. And so the topic of my talk today is biomarker testing, and I'm going to be first talking about the key biomarkers that we test for patients diagnosed with non-small cell lung cancer. Subsequently, also talking about the current standards in biomarker testing and also the barriers and challenges to biomarker testing. So the first question is, what is a biomarker? A biomarker is any gene, protein, or any other substance that can provide us more information about cancer. As you see here from this snippet, each cancer cell has a specific DNA, and the mutations or any particular proteins that are overexpressed, which are sort of cancer-causing genes or proteins, are really, what we call biomarkers from a treatment standpoint. From non-small cell lung cancer standpoint, there are a variety of biomarkers. Each person's cancer has a unique pattern of biomarkers, and knowing this is important specifically for non-small cell lung cancer because it may affect how certain cancer treatments work and may help choose the right cancer treatment for each patient. When we talk about biomarkers for non-small cell lung cancer, I like to think of two key sort of buckets of biomarkers which are important. One is essentially the immunotherapy biomarkers, which help us to select immunotherapies for our patients. Typically, we think about anti-tumor immunity through the T cells and then the tumor cells. Certain tumor cells may express a protein called PD-L1, which can actually inhibit the immune response, resulting in tumor growth. And so this protein is very important because also the immunotherapies that we have today work through this mechanism by inhibiting this inhibition of our anti-tumor immunity and subsequently sort of priming our immune system for anti-cancer properties. And the way we measure PD-L1 levels, which serves as an important biomarker, specifically when we talk about immunotherapy, is through looking at the pathology under the microscope from the tissue biopsy, and essentially through various staining techniques, trying to calculate the percentage of cells which actually express PD-L1. And compare that to the total number of tumor cells and come up with a number which is sort of ranging from 0 to 100%. The more the PD-L1 percentage, the higher the likelihood in general, the higher the likelihood for response to immunotherapy from the tumor standpoint. The other important biomarker, and you're going to hear a lot about this today, is basically the driver alterations, meaning that the alterations in a particular tumor cells which are driving cancer and tumor growth. As you know, all cells will have DNA, which is generally non-mutated. When cells acquire DNA alterations, there may be tumor formation. Now, the alterations in the DNA can occur in a variety of flavors, so to speak. It can be an activating mutation when a mutated DNA can downstream lead to an activated protein and increased activity. This is the case when we talk about non-small cell lung cancer. This is the case for KRAS G12C, EGFR, and other mutated non-small cell lung cancer tumors. The other variety of driver alteration is fusions, essentially leading to fusion of one gene to another, causing a fusion protein, which can drive tumor growth. This is what we find in ALK and ROS and RET, so some of the fusion-driven non-small cell lung cancers. And finally, there may be also gene amplifications where there's a variety of genes that may have many more copies of the gene than normal, leading to increased protein activity and uncontrolled cell growth. When we talk about non-small cell lung cancer today, there are a variety of driver mutations that we would check for, given that if there is a presence of a driver mutation identified on a non-small cell lung cancer tumor specimen, we would think that it may be more responsive to particular targeted treatment if we have one to that particular driver mutation. Here is the prevalence of driver mutations found in lung adenocarcinoma. As you see, KRAS and EGFR are sort of the most common ones, but also frequently we would find ALK, ROS1, BRAF, HER2, and others, which we will be talking about in later sessions today. And why is biomarker testing important? And it is important because that is what our progress in treatment of non-small cell lung cancer has hinged upon over the last 2 decades. This is just to sort of drive home the point. If you think about treatment algorithm for non-small cell lung cancer, a couple of decades ago, it was essentially chemotherapy for all types of non-small cell lung cancer. But today, you can see that this algorithm of treatment is sort of much, much more complex, which is driven both by actionable mutations, as I mentioned, as well as the PD-L1 percentage. And again, this slide is not meant to show the details, but really showing how the progress of treatment in non-small cell lung cancer has really hinged upon these biomarkers. So what specimens do we use for biomarker testing? The gold standard is a tissue biopsy or core needle biopsy. For early stage non-small cell lung cancer, surgical specimens, if available, serve as a very important sort of resource or specimen for biomarker testing. Sometimes we do use cytological slides and material, especially when pleural effusion and other sort of presentations where we could spin the fluid and then use the precipitated cells to sort of test for these biomarkers. A new and emerging, and I guess now sort of becoming more and more standard of care technique is called liquid biopsy. Essentially, what we have found is if we use a blood sample and spin it down with centrifuge or using high vigorous techniques using machines, what we can identify is there will be a certain section of the blood that we collect, which is known as plasma. And within the plasma may be some freely circulating DNA from the tumor cells that has been shed, which can also help us in identifying particular biomarkers of interest. So this is also known as liquid biopsy. And essentially what it is sort of taking a blood sample. In the blood vessels, you will see there are numerous cells, including our own immune cells, red blood cells, but we also may identify certain freely circulating DNA, which may belong to the tumor, especially once we identify mutations in these particular DNAs. And this is also known as circulating tumor DNA or liquid biopsy. How does it compare with tissue biopsy? There are both advantages and certain sort of drawbacks to liquid biopsy. I think the biggest advantage is that it is convenient, it is less invasive, doesn't require a tissue biopsy or a procedure which would be needed for a tissue biopsy. The other benefit is we think that it may also reflect the tumor heterogeneity, meaning that if there are multiple sites where tumor may be present, as is depicted in this diagram, if it's there in the liver, maybe in the lungs, that each tumor site may have a different sort of genetic flavor, if you will. And so it's important with liquid biopsy, we may be able to identify that tumor heterogeneity, which may not be always possible with tissue biopsy. The other benefit is that it has usually a shorter turnaround time for the genetic testing results compared to tissue biopsy. However, tissue biopsy is still gold standard, especially when we are trying to identify the nature of the tumor, the histology of the tumor, if there is any transformation to a different type of tumor from adenocarcinoma to small cell lung cancer and others. So tissue biopsy and liquid biopsy, I would think of them as more of a complementary testing rather than one replacing the other. But really, this has changed how we treat, especially in cases where getting tissue biopsy may be difficult for any particular reason in that particular case. So now I want to shift gears a little bit to talk about the current standards in biomarker testing. So the current recommendations by the NCCN guidelines, which are the national and sort of international guidelines that a lot of centers, both in the US, Canada, but also worldwide, will follow. Biomarker testing that is recommended for non-small cell lung cancer includes a whole host of essentially driver alterations like we described earlier, including the PD-L1 percentage testing to dictate therapy. And again, this is important because based specifically for the genetic alterations, based on the genetic alteration identified in a particular tumor, we will have different therapeutic options available for our patients. Again, this is just showing some of the therapies that are currently available and used in standard practice. But again, just to drive home the point that this is very specific and the biomarkers will be helping us to identify specific therapies for each of the patients that we see in our clinics. The best practices for advanced non-small cell lung cancer, essentially at diagnosis, we would definitely want molecular profiling. Reflex testing is usually preferred, so to make sure that the testing is correctly implemented. And essentially, it could be on tissue biopsy, if available, to identify standard of care therapies. When tissue biopsy is not available, as I mentioned, ctDNA, circulating tumor DNA, or liquid biopsy would be preferred, again, to identify any particular therapeutic target. If we are able to identify that even on liquid biopsy, we would generally treat with standard of care therapy based on oncogenic drivers. If we are not able to find any genetic alterations in both tissue and liquid biopsy, generally we tend to think of those cases or tumors as being non-oncogene driven and will usually have some sort of treatment with chemotherapy or immunotherapy or both. This is also important in the setting of advanced non-small cell lung cancer where the tumors have relapsed or are refractory. Again, the idea with the molecular testing, either with liquid biopsy or tissue specimen, being to identify the resistance mutations, particularly for that particular tumor. If we are able to identify a particular resistance mutation to which we may have therapies today, then those would be the standard of care therapies for those oncogene drivers. If not, then again, if tissue biopsy has not been established for the relapsed refractory cases, it is important to do that in order to identify whether there has been a change in histology or some other information that we may have missed from the liquid biopsy alone. Finally, I would like to talk a little bit about the barriers to biomarker testing. As I mentioned in the few slides earlier, that biomarker testing is sort of now the current standard of care, and every patient that we see with non-small cell lung cancer, specifically with advanced stages, but also now more and more in the earlier stage setting, needs biomarker testing. We need to identify genetic alterations. We need to identify PD-L1 status to help us make decisions for treatment. However, having said that, there are barriers to such testing. There are challenges, and unfortunately, biomarker testing is not universally applied as it should be. And so now I want to just talk about some of the barriers and challenges that we face in biomarker testing. This snippet is from an excellent paper by Sadik and colleagues that was published last year. Essentially, they studied patients with newly diagnosed advanced non-small cell lung cancer who were potentially eligible for targeted therapy, about 1,000 patients. And they found that only 356 of these patients were actually treated with targeted therapy. So really, there are a lot of practice gaps that have been identified, which are prohibiting us or preventing us from truly applying precision medicine or precision oncology as we would like. I think some of the biggest barriers here is actually ordering and obtaining biomarker testing. As you see, about 18% of patients did not have this as standard of care in this particular study. And the other issue or barrier is the treatment decision making, and actually for the patients where we've identified genetic drivers or immunotherapy-based biomarkers, to actually apply those results in treatment decision-making. Again, here you see about 30% of patients did not receive treatments as per their biomarker testing. And some of the issues in terms of ordering the test, physicians not ordering the testing, lack of awareness of the current guidelines for non-small cell lung cancer testing, as well as insurance challenges are what truly prohibit ordering of the biomarker test. And in terms of treatment decision-making, again, targeted treatments not being selected despite positive test result or report indicating no therapy or alternative were the major reasons for why this practice gaps occurred. There's more data and evidence showing that the adoption of biomarker testing is substandard. This is a sort of slightly older study now, a retrospective study from 2016 to 2020 among the community oncology sites, again showing there is inadequate testing in community oncology setting. On this right panel here, if we look at the numbers, here this particular study only included the 5 of the biomarkers that we discussed. And again, among these 5, if you look at the patients, the number of patients who actually had biomarkers tested before initiation of first line, really sort of falling between 25 to 55%. And again, this really should be 100% is what the aim is and the goal is. And again, of these patients, biomarker-directed treatment, as you see here, also varied widely among the different biomarkers that were identified, and again, identifying the same practice gap of actually applying the results of our testing paradigm. Solutions to this may be integrating these testing as reminders in our electronic medical records. This has been studied. There is this EMR-based nudge intervention workflow, which was developed by our colleagues at University of Pennsylvania, where every time the care team saw a patient who had newly diagnosed treatment-naive non-small cell lung cancer, there would be a trigger to the provider team to to really identify whether a plasma-based next-generation sequencing biomarker testing assay was indicated, and if it was indicated, was it ordered, or it would help an auto-generated NGS order, which actually did increase the amount of biomarker testing. On the right panel here, they look, are the results from this study. They looked at 526 patients, 381 in the pre-intervention and 145 in the post-intervention cohort. And essentially with this sort of nudge, as well as the email-based Reflex Alert program workflows, they were able to post-intervention, there was a significant increase in ordering of tissue as well as plasma next-generation sequencing, comprehensive next-generation sequencing, as well as the next-generation sequencing prior to the first-line therapy in the post-intervention setting. So this potentially could serve as a solution to make sure that we are ordering biomarker testing when it is truly indicated for our patients, and hopefully we're not missing as many as we saw in some of the earlier studies. The other issue has been insurance coverage. There was a survey by a marketing sort of communications company showing among academic medical centers, community and commercial payers, and really trying to identify barriers to NGS as a top barrier to next-generation sequencing testing. In March of 2018, Medicare announced coverage of next-generation sequencing for patients with cancer as part of their national coverage determination. This was for all patients with cancer, not just specifically for non-small cell lung cancer. But I think some of these efforts might be needed in order to make sure that cost doesn't become a barrier to biomarker testing. So potentially national coverage determination and other such advocacy, and other such efforts through advocacy may be potentially a solution to the cost barrier for biomarker testing. There was this study which was conducted in 2021, almost 2 to 3 years after the NCD was announced. And it did show that the percentage of patients receiving next-generation sequencing testing within 60 days here for non-small cell lung cancer patients, this is pre the coverage determination announcement, and post-coverage determination announcement, we do see there is an increase. It's still at 45%. Again, we need it to be higher, but this potentially could be one of the solutions to, again, broadening access to testing. The other interesting thing that this particular study demonstrated was, with the coverage determination being just for Medicare, there was quite a significant increase in NGS testing for patients who have Medicare-based insurance, and there were increase in NGS tests even for patients with commercial insurance, but not so much for patients who were in state Medicaid programs. So again, this sort of Medicare-based policy or national policy may be helpful in general, but still may widen gaps and disparities based on the patient's insurance type. So again, this may not occur equally across all insurance types. And again, further efforts beyond coverage policies are needed to ensure equitable access to the benefits of precision medicine and eliminating cost as a barrier to biomarker testing. And finally, as we discussed, one of the final practice gaps is actual administration of biomarker-driven therapy. Another study, again, a few years ago now, showed that only a minority of patients received biomarker-driven treatment, even when driver mutation was detected. Now, granted, this is a few years ago, but 45% is really a less of a number than what we would like to see in this particular case. This study also identified a lot of patients received immunotherapy, often prescribed instead of targeted therapy, even when the molecular results were available. And I suspect some of this may be because the genetic testing and driver alteration testing takes quite a few weeks, and generally it is a very uncomfortable time both for the patient as well as for the provider to just wait for the genetic testing results. But I think as we've done this more and more, I think both the providers and patients have felt more comfortable waiting for that, because as you see, and you will see during the rest of the program today, that this is really, really important, because if we are able to identify a genetic driver and target that genetic driver, we we have seen much, much more improved outcomes compared to treating everyone the same way as we did in the 90s. Some of the primary reasons for failing to act on positive predictive biomarker results, this, again, the study from 2022 that I showed you with the practice gaps identified lack of awareness of targeted treatment as one of the causes of actually not administering these treatments to patients. Social determinants of health access and disparities, as well as again, cost of therapies and insurance coverage being another concern and barrier to administration of therapy. So again, the access and affordability are very, very key issues in biomarker-driven therapy. We are able to identify the biomarkers that are present, but do we have access to the treatments for our patients? This is a study which was recently published looking at EGFR and ALK TKIs administration for patients with non-small cell lung cancer in state Medicaid programs. And again, here it's showing about 30 out of the 33 to 34 states that the author studied in this paper actually had lower than expected range of patients being treated with EGFR and ALK TKIs. So again, access is a big issue. It should not be a barrier. The state that you live in should not be determining the type of treatment you get for your non-small cell lung cancer. So really, this needs to change. And again, more advocacy is needed in this particular area. Affordability is another important issue. Now, a couple of years ago, our team looked at the pricing for EGFR inhibitors and ALK inhibitors and how over the last few years, the prices had increased, not just increased, but increased over the consumer price index over those years. And again, making affordability and out-of-pocket expenses an important issue. And I think it's very important for all of us to realize that for patients who cannot afford therapy, regardless of the tumor mutational or tumor PD-L1 status, the tumor response rate is going to be 0% if we are not able to administer these therapies to our patients. And so finally, I think I would like to summarize with some potential solutions. As I mentioned, testing, awareness of testing, improving our assays, improving our coverage for liquid biopsy and other infrastructure capabilities like we saw, implementing this to make sure that we are ordering appropriate testing for our patients, expanding the coverage and advocating for patient support systems, out-of-pocket estimation, global expansion of the coverage for biomarker testing, as well as finally administering treatments based on biomarker testing and advocating for coverage of therapies which improve outcomes for our patients is needed. And that is something both the patients and the providers should be teaming up to do. And so with that, I would like to conclude and thank you so much for your attention today.
Great. Thank you so much, Dr. Desai, for a wonderful talk. And there'll be an opportunity for questions, but please keep them coming in the chat. It's been highly interactive so far, and we're looking forward to a nice interaction with folks during some of the dedicated sessions. And so next, it's my privilege and honor to be introducing Dr. Joshua Royce. He's a thoracic medical oncologist at Georgetown University, assistant professor at Georgetown University Medical Center, where he specializes in lung cancer, mesothelioma and thymoma, and he has particular scientific interest in resistance mechanisms. He received the YA from the Concord Cancer Foundation from ASCO 2019 for his research, and he will be discussing non-metastatic disease and targeted therapies.
All right, thank you, Dr. Patel. Let me just share my screen here. Okay, sorry. All right, can we see and hear me okay? Are we good?
Yes.
Perfect, thank you. Thanks for the audio. I can't see the platform anymore. So my name is Dr. Joshua Royce. I'm a thoracic medical oncologist at Georgetown University and assistant professor of medicine. And I'm privileged to be here today to speak on non-metastatic disease and targeted therapies, a very rapidly evolving space. These are my disclosures. I want to begin by discussing kind of a visual glossary of terms. I might be throwing in some medicalese accidentally, and I just want to describe some terms and what they mean in the context of targeted therapies in non-metastatic disease. So when we look at someone who's potentially can get surgery for what we say a resectable non-small cell lung cancer, if we give treatment before surgery, medical treatments, that's called neoadjuvant. That means giving chemotherapy, immunotherapy, targeted therapy before surgery. If we give these treatments after surgery, we refer to that as adjuvant, giving medical therapies after surgery. And then more recently, as we have more evolving trials, we've kind of referred to lumping treatment both before and after surgery as kind of a perioperative technique. So that's one thing I wanted to get across. The second has to do with outcomes and disease-free survival and overall survival. You might hear us throwing these terms around occasionally. And so let's take, for example, a 10-patient clinical trial. And a year later, you look at follow-up of a 10-patient trial in patients who have a curable lung cancer. Of these 10 patients, 5 are alive and disease-free. 3 are alive, but unfortunately have experienced recurrence of their cancer, and 2 unfortunately have passed. At this 1-year time point, the disease-free survival, meaning percentage of patients who are alive and without recurrence of their cancer, would be 50%. However, the 1-year survival rate would actually be 80% because while 5 patients are alive and disease-free, there are actually 3 who are alive and have experienced cancer recurrence. So just an explanation for some terms that we utilize in this disease setting. So where were we in treatment status for patients? Up until very recently, the only thing we offered patients with resectable lung cancer was chemotherapy. And you could see the long-term survival outcomes were really abysmal for this stage of disease. For stage 1B to 3B, survival rates of 24 to 73% at 5 years. And really the benefit of chemotherapy was limited to about 5% at 5 years, whether it was given before surgery, neoadjuvant, or after surgery, adjuvant. You could see on these curves, I know these slides appear a little small, so definitely download these, look at these more closely, but I'll try to discuss them in detail. So the top line of both of these curves is giving chemo, and the bottom line is no chemo. And you can see, while there's a benefit, it is not as high as we'd like to see. So how has this field changed? And really the big trial here was the phase 3 ADAURA trial. This trial randomized patients with completely resected stage 1B to 3A EGFR mutated lung cancer to osimertinib, our frontline targeted therapy standard for EGFR mutated lung cancer, or placebo. And I'm going to walk you through the study design here. So on the left are the inclusion criteria. So this study included patients with, again, resected stage 1B to 3A non-small cell lung cancer, and this utilized a slightly older staging system. So roughly translated, this correlates mostly with stage 2 and 3A patients with today's staging, though it did include some stage 1. These patients had to have an activating EGFR mutation. So our classic EGFR activating mutations, exon 19 deletion and exon 21 L858R mutation. And patients were randomized, patients were then stratified by disease stage, by the type of EGFR mutation, by race, and then randomized 1-to-1 to receive 3 years of osimertinib or placebo. The primary endpoint, so how the study was designed to look at a clinical endpoint, was to look at disease-free survival, as I said earlier, time to cancer recurrence in the higher stage 2 and 3A patients, but key secondary endpoints did include overall survival. So as this figure shows, the disease-free survival was remarkably positive with this trial. You could see out 4 years from the beginning of adjuvant targeted therapy, an incredible disease-free survival benefit with 70% of patients who received Tagrisso at the stage 2 and 3A patients alive and disease-free at 4 years, compared to 29% who received placebo. And this roughly translated to a 77% disease-free survival benefit for osimertinib over placebo. Again, this is in the primary population that was looked at, the stage 2 and 3A patients. And when looking at all patients, so including the 1B patients, a very similar, very impressive outcomes, again, with a 73% disease-free survival advantage. Now, because of this data, in 2020, the FDA actually approved osimertinib for therapy after surgery Interestingly enough, for all patients with EGFR mutated lung cancer with these alterations in exon 19 deletion and 21L858R mutation. So irrespective of disease stage, and what this really speaks toward is that we should really be considering next generation sequencing for all patients with a resected non-small cell lung cancer to evaluate for an EGFR mutation. What are some other key outcomes here? So importantly, osimertinib is effective in the brain and so can shrink down brain metastases in patients who have advanced disease, and also can help to prevent metastases from occurring in the brain in this setting. So what this figure shows is that what we call central nervous system disease-free survival. So the percentage of patients who are alive and without cancer occurring in the brain, and you could see at 4 years for those who received osimertinib, that percentage was 90% compared to 75% who received placebo. Now, no therapy is without side effects. We view this as primarily a tolerable safety profile. And for those on this presentation who know these side effects, who've experienced them, more commonly was seen diarrhea, nail changes, dry skin, itching. However, just to break down, what low grade does not mean that this is something that doesn't affect quality of life. And for example, a grade 1 diarrhea means increase in stools up to 4 times or just below 4 times per day above your baseline. Grade 2 means 4 to 6 times above baseline. So while we refer to these as low grade and we don't code these as serious, obviously these are side effects that can affect one's quality of life. Now, an important question and point is, do the chances of cancer coming back increase after stopping osimertinib? Now, these are the disease-free survival curves broken down by stage. And what I mark here with this red line is the duration of treatment. Remember, osimertinib was given for 3 years. And the slope of these curves indicate patients who are experiencing a recurrence. And so as each patient experiences a recurrence, that number drops from that 1 at the top of the curve all the way down. And you could see here that particularly for the stage 2 and 3A patients, after osimertinib was stopped, that slope of the curve becomes a lot more steep, indicating a higher rate of cancer recurrences in those who had received Tagrisso. And so for us in the lung cancer community, we were very curious to see why this therapy obviously does benefit disease-free survival. If recurrences increase, will we see a true overall survival benefit for our patients? And luckily enough, earlier this year at ASCO, we did see an overall survival benefit result from this study. And at 5 years, in the primary population of stage 2 and 3A patients, 85% of patients were alive who received Tagrisso compared to 73% who received placebo, translating roughly into a 51% overall survival benefit for osimertinib versus placebo. And just a side note, when I talk about this benefit, this refers to a hazard ratio, which is statistically how we look at benefit for a lot of these therapies. In the total population, including stage 1B, also a similar, very exciting survival benefit for osimertinib or Tagrisso, the trade name, compared to placebo. Now, when broken down by disease stage, you can see here the benefit was most pronounced in those with stage 3A disease, where we saw a nearly 20% numerical increase in survival at 5 years for osimertinib compared to placebo, but there was clear benefit observed across disease stage that was included in this study. So what are some important points and questions for the ADAURA trial? So number 1, osimertinib improves disease-free and overall survival in resected stage 1B to 3A EGFR mutated lung cancer. Again, this was by the earlier staging system, but based off the FDA approval, osimertinib can be given for all patients with an EGFR mutated resected non-small cell lung cancer. Importantly, in my opinion, osimertinib does not replace chemotherapy when indicated. This is typically stage 2 and 3 disease because we do know there is a survival benefit there. I think one question that we're still grappling with are more patients truly cured with osimertinib after surgery, or does just a very prolonged delay in recurrences lead to the survival benefit that we've seen? In a practical sense, I don't think it really matters because we know there's an overwhelming clinical benefit and this therapy clearly helps patients and is indicated, but it's more of an academic question here. To that point, how long should patients take osimertinib after surgery? Is 3 years long enough, or should we continue longer? And on the flip side, are there some patients who are cured with just surgery and don't need osimertinib? And I think lastly, and this is an important point, is can this approach be used for patients with other driver mutations, such as ALK, RET, ROS1? And I think there are key factors here. Number one, you must know that understand there's a lack of data here. So everything we would do in this scenario is extrapolating from ADAURA. But there are key attributes that drugs, I think, need to have to be considered here. And that includes very effective therapies that have a tolerable safety profile, or one could take this for 3+ years. And the drugs must have an ability to get into the brain. And as Dr. Desai mentioned earlier, financial toxicity and insurance coverage, very important here as well, especially since strictly speaking, this is not an indication that's yet FDA approved. So what are some ongoing trials addressing osimertinib, some of these questions? So for duration of therapy, there's the phase 2 Target trial, which is looking at 5 years of osimertinib for stage 2 and 3B patients. And on the right is the phase 3 ADAURA-2 trial, which is looking at osimertinib in earlier stage 1A, 2, and A3 patients. A trial that we hope to see results for soon in the ALK space is the phase 3 ALINA trial, which is looking at patients with resected stage 1B to 3A non-small cell lung cancer randomized to 2 years of alectinib, which is one of our frontline targeted therapies for ALK fusion positive disease, versus chemotherapy. Transitioning now to giving targeted therapies before surgery, what we call neoadjuvant. And I will say there is limited data for our more modern targeted therapies in this space, but we are seeing some early data from trials for osimertinib preceding surgery in EGFR mutated lung cancer. And this is somewhat of a complex table and perhaps made even more complex by the size on your screen. But a few key points here. Number one, there's a high percentage of imaging responses with lymph node response and actually downstaging of the tumor, which translates into a high rate of surgical resection and complete tumor removal. So what this indicates is osimertinib can effectively shrink tumors with high rates of complete surgery after giving osimertinib, at least in these early studies. However, when we look at pathologic response, we see something interesting. So MPR, that means major pathologic response, which means that when the surgeon goes to cut out the tumor, there's less than or equal to 10% tumor in the specimen that's been removed. PCR, pathologic complete response, means when the surgeon goes to cut out the tumor, there's actually under the microscope no tumor left after the treatment that was given. And you could see that these rates are quite low with osimertinib. And what that means, while these are small early studies, is that osimertinib alone is unlikely to fully eradicate and cure patients with resectable lung cancer, suggesting that surgery and perhaps additional adjuvant therapy is needed in this case. So there are ongoing phase 3 studies looking at perioperative, so before and after targeted therapy. This is the phase 3 NEO-ADAURA trial, which is looking at patients with resectable stage 2 to 3B EGFR mutated lung cancer, randomizing 1:1:1 to chemo, or chemo plus osimertinib, or osimertinib alone, followed by surgery, and then optimal adjuvant, meaning medical therapies after surgery, including up to 3 years of osimertinib. This is a basket trial, or I should say umbrella trial, that includes multiple different cohorts of driver mutations with appropriate targeted therapy being administered before surgery, and then a similar design of adjuvant, meaning after surgery, medical therapy with targeted therapy included. And this is not all inclusive, but these are some other trials of RET, MET, KRAS that are designed similarly to be given both before and after surgery. So you'll notice I have not mentioned immunotherapy at all thus far. So what about immunotherapy in patients with driver mutations who potentially can be cured with surgery? Importantly, in patients with driver mutations with stage 4 disease, immunotherapy by itself is largely ineffective. We actually have 2 large phase 3 trials of EGFR mutated lung cancer that showed that adding immunotherapy to chemotherapy had no demonstrated clinical benefit compared to chemotherapy alone. Now, you might ask, well, what's the harm of at least trying immunotherapy, seeing it benefits a lot of people? But we do know that giving targeted therapy after immunotherapy can lead to risk for serious toxicity. So this is not benign and can get into a tricky situation if one needs to start these targeted agents. An additional important point is that most immunotherapy trials for patients with resectable lung cancer excluded patients with driver mutations. And those that included these patients were not designed to evaluate the effectiveness of immunotherapy in patients with driver mutations. So it's my opinion that immunotherapy should not be considered on a routine basis for most patients with driver mutations, with some notable exceptions, including KRAS and some others who have surgically resectable lung cancer. So some additional considerations and questions for targeted therapy before surgery. I think the likely outcome here is that we're going to see appropriate targeted therapy leading to effective tumor shrinkage, which can hopefully improve the ability for patients to get a complete tumor removal with their surgery and perhaps less complex surgeries. So will this change practice? Will this lead to FDA approval? I think, we need to see. Targeted therapy before surgery is unlikely to replace the need for continuation of targeted therapy after surgery. Due to the pathologic outcomes that we've seen, I think that targeted therapy will need to be continued after surgery as well. If results of NeoADAURA are positive, so giving targeted therapy before surgery, will we extrapolate this approach with other driver mutations? I think that remains to be seen. How will chemotherapy be sequenced? Is there still a role for stage 2 and 3? I think there likely is, but we need to see that. And then, as I mentioned before, immunotherapy-based approaches in the perioperative setting should not be pursued for most patients, though mutation subtype, smoking history, other factors may play a role here. So in the remaining moments, I want to touch briefly on locally advanced unresectable lung cancer with a driver mutation. So our standard of care for patients with locally advanced lung cancer who can't get surgery is to give curative intent chemotherapy with radiation, followed by immunotherapy. That was shown in the large phase 3 Pacific trial that randomized patients after chemoradiation to durvalumab immunotherapy or placebo. And these are the outcomes from that trial. And I won't go into the detail, but the blue lines were the immunotherapy, and you could see both in time to cancer coming back, which is progression-free survival, I should say time to cancer growing, progression-free survival, or overall survival, we saw improvement with immunotherapy. But importantly, the study did not assess driver mutation status of patients. And in the lung cancer community, I think we were all a little skeptical of the immunotherapy benefit in this approach. Now, there is limited data here. This is a subgroup analysis from this trial of EGFR mutated patients, and I'm sure it's hard to see, but only 24 patients with EGFR mutations received durvalumab and 11 received placebo. But with that being said, there was not a clear sign of clinical benefit with the addition of durvalumab for progression-free or overall survival. So there are several trials ongoing. This is the phase 3 LAURA study that looks at giving osimertinib or placebo after definitive chemoradiation for patients with stage 3 unresectable lung cancer. And then this is a platform trial that's looking at a few other driver mutation populations of giving appropriate targeted agent versus immunotherapy for a stage 3 unresectable lung cancer. So a few key points and questions from this disease stage. Number one, I do suspect that LAURA and other trials in this setting will be positive. But in the absence of data, should we extrapolate results from ADAURA, so giving osimertinib after surgery, and consider targeted therapy after chemoradiotherapy now? I, for one, am starting to look at this with some population of patients, but it's an important question. And then what treatment duration is most appropriate? Is it 3 years? Is it indefinite? And as I've alluded to earlier, what subgroups are most appropriate for this approach? And again, that requires an effective therapy with good brain penetration, tolerable safety profile, and importantly, something that can be financially covered with insurance. So importantly, what can you do? Number one, ask and advocate for next generation sequencing. You won't be able to have these discussions and get the most directed therapy without knowing the molecular status of the cancer. Number two, talk to your medical oncologist about the relative pros and cons of targeted therapy, because most of the settings that I've talked about are not FDA approved indications, and it's important to have these discussions. Engage patient advocacy groups to learn more about these therapies and connect with patients who are taking them, perhaps in the same setting that you're considering. And plan redundancy, please ask and advocate for next generation sequencing. If you have a localized cancer, you might see a lung doctor and then a surgeon, but never be referred to a medical oncologist. And so it's important to ask to see a medical oncologist, ask for next generation sequencing so that you can really determine the biologic nature of the cancer. So in conclusion, osimertinib improves disease-free and overall survival in resected stage 1B to 3A EGFR mutated lung cancer and is approved for all patients with resected lung cancer with an EGFR exon 19 deletion or 21L858R mutation. Trials of targeted therapy are ongoing for patients with surgery or patients after surgery, before surgery, and after curative intent chemoradiotherapy. However, can we already now extrapolate our approach of giving osimertinib after surgery to those with other types of driver mutations and to those after curative intent with chemoradiotherapy? I think the answer to this is yes, and we're already starting to do this for some types of subgroups of driver mutations. There are many important questions that remain, however, including what is the appropriate duration of treatment, who truly needs targeted therapy, who is cured by surgery with or without chemo. As I alluded to earlier, immunotherapy is not likely to be beneficial for most patients in this setting. And then I cannot stress the importance enough. Next generation sequencing to assess for driver mutations is critically important to determine the most appropriate treatment approach. And so with that, I thank you for your attention. I look forward to discussions. I include my email here. Don't hesitate to reach out to me with any questions you might have. Happy to help. Thank you.
So terrific discussion, Dr. Royce. That was just completely on point. Thank you so much. And I'm sure there will be lots of questions that we can go over in the Q&A session. Now, everyone, after lunch, we are going to have several breakout sessions that are dedicated to targeted therapy for the respective genomic subsets of lung cancer. For the very next session, we thought it would be helpful to take a step back and review how we consider adding to targeted therapy, or perhaps what are the options after targeted therapies have been tried. And so for this session, we're really fortunate to have Dr. Puneeth Iyengar join us as the faculty speaker. Dr. Iyengar is currently an attending physician and director of the metastatic service in the Department of Radiation Oncology at the Sloan Kettering Cancer Center. He has clinical research that's focused on developing synergy between local therapy and systemic therapy for advanced lung cancer. So I'm sure he has a lot of insights to offer for us on today's topic. Dr. Iyengar.
Thank you very much, Dr. Lin. I really appreciate it. Let me share my screen. Let's see here. And okay, share. And then, and I hope everyone can see that. So at the end of the day, Akash and Joshua really set the stage for what we're going to talk about now. And it's really maximizing the benefit of TKIs and maximizing their impact with respect to durability of outcomes. And how do we really think about doing that? We can think about doing that multiple ways. One is adding local therapy, which is going to be the bulk of what I'm going to talk about. I think it's an exciting new area, an opportunity to do something we've not really done in the metastatic state. And then the idea of optimizing systemic therapy, I'll put that at the very end because there are many medical oncologists and multidisciplinary team members who are working on that approach. So, as we know, we all know this is not anything new to this audience. There are 239,000 expected cases of non-small cell lung cancer in 2023, or lung cancer in general, as per the ACS. Majority of the non-small cell lung cancer patients are going to have stage 4 disease. And so we have multiple FDA-approved regimens that are supporting that approach. And the real question, in my mind, as part of the multidisciplinary team, is we have realized an incredible improvement in survival outcomes associated with this new agents, whether it's immunotherapy, whether it's targeted therapy, and it's associated, and I will not downplay side effects associated with these therapies, but significantly improved toxicity profiles with respect to cytotoxics. But we want, as a team of patients and physicians, we want to optimize durability of outcomes for a majority of our patients. And so that's where, the question becomes, when a TKI is working in a majority of sites, but there are maybe a few sites of disease that are progressing, should it be our instinct to switch therapies like it has been historically to a second-line systemic therapy? Or should we try to do something different to try to optimize the continued use of that TKI? And so, as all of you know, in this audience, biology is really what's driving our outcomes for advanced non-small cell lung cancer. Whether it's patients with EGFR, ALK, KRAS, RET, MET, ROS mutations, we have now developed a plethora of optimized treatment approaches, at least in the first line setting, to navigate these different disease entities. But as radiation oncologists started thinking about these problems in the 1990s, Wetzelbaum and Hellman, who were at the University of Chicago, started wondering, is there a way to add local therapy in the form of radiation and/or surgery to optimize the durability of our outcomes and to help synergize with systemic therapy to improve survival outcomes? And so that's what this idea of limited versus widely metastatic disease and the idea of oligometastatic disease, that's how it gained hold. And so, as all of you know, disease evolves. It starts as a primary cancer. It evolves in some patients to development of metastatic disease. But Hellman and Wexelbaum thought that maybe it evolves to a position where there are only a few lesions and few sites that the primary lesions metastasize through to. And eventually, due to progression of disease, failure of therapy, a combination of both, it goes more widely. And what Hellman and Wexelbaum and a number of others thought was that maybe we could leverage that intermediate state to optimize disease control and durability of systemic therapy responses. And so again, as I said, biology drives survival. We need to keep that in the back of our mind as we think about the future of the synergy of potential local and systemic therapies. So again, what is the rationale for considering using local therapy for metastatic disease beyond palliation? I think the improvement of systemic therapies, the idea that even though we have improvement in systemic therapies, they're still not perfect and often do not stand alone. The idea that modern diagnostic tools, including imaging, can help identify patients at earlier stages of metastatic disease, and hopefully with screening mechanisms help with that process as well. So the idea is there a potentially chronic or curable subset? More data to support the use of local therapy. If we look at patterns of failure, what group in Colorado and others have shown is that the original sites of disease that patients have are usually the first sites in which failures occur and progression of disease occurs. So the question was, why not consider employing local therapy if we know more likely than not where the first sites of failure are going to be in the body? And this is what, again, led to this kind of innovative hypothesis that Hellman and Wexelbaum developed in the 1990s. But we actually have now significant data to suggest that this may be actually helpful. One is we have to look and congratulate our surgical oncology colleagues who, for years and decades, were aggressive with metastatic sarcoma and colorectal cancer that went to the lungs, for instance, or the liver, in resecting those aggressively and still treating patients with a very much a curative approach in the stage 4 setting. The same was done with metastatic non-small cell lung cancer that had isolated adrenal lesions. And then, of course, neurosurgeons have historically been aggressive when necessary for limited metastatic disease that's gone intracranially. And all of those studies suggested actually a benefit in survival, not just a benefit in symptoms or progression-free survival, even some suggested overall survival. So again, the ideas for using local therapy in metastatic settings or limited metastatic settings. Chemo-IO studies don't really describe patterns of failure, but in general, failures occur in first sites of disease, and responses last but don't last forever. And so that's kind of the direction that we started taking to think about this as a field in radiation oncology. It happened to coincide with the evolution of SBRT, and I hope a lot of you have heard about SBRT. It is a highly conformal, image-guided way of using radiation to treat specific depots of disease in the body. It's non-surgical. We can literally use SBRT to treat sites from the top of the head to the bottom. And quite honestly, SBRT has, if used appropriately, limited toxicity, and it was more or less perfectly suited to treat metastatic disease because, as I said, there was limited anatomic constraints as long as we followed, appropriate protocols. So I'm going to talk about a few scenarios where local therapy has been used in non-small cell lung cancer for the management of oligometastatic disease. And I'm going to really focus on the first two topics, consolidation and oligoprogression. And how do I define consolidation? I view consolidation, and the field views consolidation, as patients who have metastatic disease. They receive some frontline systemic therapy, in your case TKIs, or targeted therapy of some form or another, or immunotherapy for other patient populations in non-small cell, or in small percentages now cytotoxic chemotherapy. After about 3 months, we re-image the patients to see if they have limited sites of metastatic disease that would make them amenable to radiation. Then those patients would receive radiation or undergo surgery to those metastatic sites, as well as treatment of the primary, and the patients would move on to continue systemic therapy. And the idea was, could we improve survival outcomes, progression-free survival and overall survival, by adding radiation at that point in time after they've received some form of induction systemic therapy. So this is a complicated slide. I think you guys will all get access to this slide set, but there were multiple studies that asked this very question. When we add radiation in a randomized fashion, can we improve progression-free survival? And the three arrows allude to 3 studies that included non-small cell lung cancer patients where use of radiation improved progression-free survival significantly, in many ways, 3-fold increases in PFS. And then in 2 of the studies, the top one and the bottom one, Gomez and Palma, they also showed an overall survival benefit with the addition of that local therapy. Now, the first study, the Gomez study, did include patients with targetable mutations. It was about, for instance, EGFR was about 12% of patients. And even in the targeted therapy group, they saw a benefit with the use of local therapy. So this gave us some signal, early phase studies, not very large, that the use of radiation in a randomized fashion could actually help with not just progression-free survival, but overall survival. So there's a very interesting and exciting set of studies supporting our field's hypotheses. None of these studies, of course, incorporated immunotherapy. They were preceding that era. So as we started thinking about immunotherapy, and I'm just going to get to this explanation as a paradigm of understanding how we've started moving in the same directions with targeted therapy, specific targetable disease. Immunotherapy has shown some benefit in some early studies, but then there have been other studies, like this other one that came out of the NCI, where there was not a significant benefit. So the jury is going to be out. I'm running this trial, LU002, which is asking this very specific question. In the setting of what we call consolidation, does the addition of radiation help survival? And hopefully we'll know that the interim analysis will be done in a few weeks, which will give us a go, no go to the phase 3 portion. But in parallel, there have been a number of studies that are looking at local therapy in the setting of disease that's targetable. And so at UT Southwestern, we did a study that was with the City of Hope. It hasn't been published yet, but in a single arm phase 2 study, we finished enrollment and we're doing the analysis. Patients that had EGFR mutated disease started with osimertinib, and then after about 8 weeks of therapy, as long as they had limited number of sites of disease, we gave radiation to all of those sites, and then the patients continued on osimertinib. And this study, the key point of this study was to understand whether there would be like a benefit in terms of progression-free survival progression-free survival and overall survival compared to historical outcomes in patients who receive osimertinib alone. We did a parallel sister study with ALK rearranged disease, where we combined, in this case, ceritinib again, but this case it was a phase 2 trial where we had patients that had ALK naive disease, and then patients that also had ALK resistant disease, inhibitor resistant disease, and we basically re-imaged and then did radiation again to all of these patients and all of their disease. And again, the idea is to see in the setting of treatment naive patients or patients who receive therapy, whether the radiation will help with progression-free survival. Again, we finished enrollment on this study and hope to get some information further. There have been 2 other studies out of MD Anderson looking at a similar concept. Start with the systemic therapy in the form of osimertinib, in the top study. It's a randomized phase 2 study, and they're still, I think they've completed enrollment, and they're going to wait about a year and a half before they for a follow-up to look and see whether local therapy helps. The idea is to synergize with the systemic therapy and improving survival outcomes. And they also have a phase 1 study looking at local therapy in the setting of patients receiving brigatinib. Now, some people will ask, what about doing this upfront? What about adding radiation upfront in patients that have oligometastatic disease? Can we add radiation and see if in EGFR mutated patients, for instance, this study was published in the JNCI, and see if these patients can actually, do well. And this study was really exciting. It was published in in 2022, reported out in 2023. But the idea was that the addition of radiation upfront to metastatic disease and to the primary improved progression-free survival and overall survival. Why are we not using this for every patient now? Well, part of the reason is that if you look at the first 9 to 12 months of the study, and you're looking at these Kaplan-Meier curves, you see a very flat line. That was a little bit concerning to a number of us in the field, in that we expect patients who receive TKIs to certainly have very significant, durable progression-free survival. But we would expect some significant events within the first year, and there really were not that many in this trial. So we are waiting for larger studies to be conducted and completed before I think we change our practice patterns with this patient population. Now I'm going to switch gears real quick to talk about oligoprogression. What is oligoprogression? It's patients who have received frontline therapy and then their disease progresses. But their disease progresses only in a limited number of sites. And some people, and so at the end of the day, as we said, all patients with TKIs will eventually progress. Hopefully it's from a long time out. Some will have oligoprogression, meaning to a few sites of disease. And so the question was, with this group that was published back in 2012, is that they decided to radiate or consider radiation for those patients that had oligoprogressive disease. And so their hypothesis was that the patients that had progressive disease in a limited fashion gets radiation, that they could have an improved progression-free survival. And that was kind of what they showed in this study. So again, some evidence to suggest maybe not in the upfront setting or the consolidation setting, but after you've progressed on a frontline therapy, but in an progressive condition, there still may be benefits from local therapy. We also took this kind of role. Can we add SBRT to patients that have progressed on frontline systemic therapy, in this case, erlotinib? So we actually treated patients who had failed erlotinib, who had 6 or fewer discrete lesions with SBRT, continued the patients on erlotinib to see if it controlled disease elsewhere. And these are just some of the characteristics. But at the end of the day, we found a PFS and an OS that was quite good compared to historical patients that were just on erlotinib, who had failed 1, 2, or even 3 lines of therapy. So again, it gives us hope that these patients who may get local therapy in a selected patient population will do really well. And it actually changed the patterns of failure. The addition of radiation stopped patients from failing first in original sites of disease. What it did was it delayed failures, and when failures occurred, it was in new sites of disease, not the original sites of disease. And so that's really what we wanted to see. Unfortunately, very interestingly enough, this study preceded the era of widespread mutational testing. None of the patients that we tested had EGFR mutations. So in many ways, and then back then, remember, EGFR inhibitors were thought to be of help in the wild type EGFR setting. And now, of course, we know that that's not to be the case. But in any event, this study suggested that SBRT, again, in an oligoprogressive condition, could be helpful. So there are some randomized studies. This one is Stop Non-Small Cell Lung Cancer for Oligoprogressive Disease. That includes targeted therapies. This is HALT. It's in Europe. They are finished accrual, and we look forward to seeing the results of both of those studies, these 2 randomized studies. And so at Memorial Sloan Kettering, they recently completed a study using, again, a radiation in an oligoprogressive state to look to see if there was a benefit in the use of local therapy. And again, the idea is that we shrink the disease, but some patients will start failing and progressing in original sites of disease. Can we use local therapy? So this study included patients that had EGFR mutations that were on osimertinib. And they basically either received radiation to the local disease that progressed or did not receive radiation. And as you can see here, the patients that received radiation, the curve in red, they had a significant improvement in progression-free survival compared to the patients that did not receive radiation to their oligoprogressive disease. So again, a very interesting and positive signal in this space. But with the last few minutes, I'm going to basically say that we haven't done enough. We haven't done enough to understand when to use local therapy to better personalize our treatments for all of you. And the reason is because we failed to predict disease trajectories. All of our previous studies were basically saying we're defining oligoprogressive disease or 3 or 5 or fewer lesions. We're describing oligometastatic disease as 3 or 5 or fewer lesions. That number is a snapshot in time. It is not giving us a dynamic understanding of disease trajectories. And so I will call all of us to start thinking about how, as a field, as patients, to push for the idea that we need to do larger scale studies, real world analyses to better understand what the true trajectory of metastatic disease is in the setting of therapy and across time. Only then will we be able to learn whether local therapy will be of benefit or not. So, as I said, this is a really rudimentary set of curves that I drew out that suggested that at diagnosis or when we put these patients on study, they may have 3 METs. But I have no way of predicting whether 6 months from now they have 20 METs, 6 months from now they have 1 MET. And that information is vitally critical for us to better understand how to use local therapy in the most optimal fashion. And it's about is the disease that we're seeing the tip of the iceberg, or is it all the disease that we're going to see for years? And so, I'm not going to belabor the point, but there are a number of lessons that we can learn. And I'm just going to end with this slide. But the real key point is that until we understand with real world data and with kind of big data analyses, the disease trajectories of patients over time on certain therapies, then we really will not be able to personalize our approaches of using local therapy to manage patients with metastatic disease. But I would say for the time being, I think we're doing an incredibly good job of, at least with the limited data we have, identifying patients with oligoprogressive or oligometastatic disease. And we're actually seeing clinical trial signals of benefit in this patient population. So I think more information is needed, but the trials so far have been very encouraging. And I think this is a way for us to look in the future to add local therapy to systemic therapy, especially targetable agents, in order to optimize durability of treatment response. And with that, I'll end, and I thank you very much.
Really a wonderful discussion by Dr. Iyengar. Thank you so much. Next, it's my honor and privilege to be introducing our next speaker, Dr. Kristen Higgins. And she's an associate professor and vice chair of clinical research in the Department of Radiation Oncology at Emory School of Medicine. She serves as the medical director of radiation oncology at the Emory Clinic. She's board certified and she's involved in multiple professional societies, member of the NRG Board of Directors, and RTOG Foundation Communications Committee. And one of the things you'll see in today's program is it really takes a team to help best take care of patients. And we could be at an Astro plenary session and we'd get to hear from folks, some of Dr. Iyengar's and Dr. Higgins' caliber. And so with that, I'd like to invite her to join to moderate our discussion. Perfect.
Hello. It's good to be here. I hope everybody can see me and hear me all right.
Yep, we can see and hear you. And I gave you a very nice introduction, Dr. Iyengar will tell you. I left no stone unturned.
Wonderful. Yes, no, I thought Dr. Iyengar's talk was very good, and I think it succinctly touched on all of the points of using radiation in patients that have targetable mutations and take targeted therapy, and different times that we can come in with radiation and potentially keep somebody on their drug therapy longer. And it's really sort of an area where we see a lot of patients every day, and there's a lot of different and unique clinical scenarios that present themselves. But there are a lot of great questions, and I'm happy to pose some of these. I can ask one interesting question that I saw on the chat was regarding a patient that had a lung metastasis that was on targeted therapy and was wanting to get treatment with stereotactic radiation and wasn't able to hold their breath. And the question was, is it still feasible for the patient to get radiation? Do you have to use these breath hold techniques in order to deliver radiation safely? So Dr. Iyengar, what do you think about that? Do you want to give your opinion on what you do at Memorial Sloan Kettering in these situations?
Yeah, you absolutely don't need to be able to hold your breath to receive SBRT safely. In fact, I would anticipate that a lot of our patients would not be able to for one reason or another. So we use something called abdominal compression. And basically what that is it's a little bit of pressure that's placed on the diaphragm, which kind of promotes you to breathe more from your accessory muscles, shorter, shallower breaths than from down below in your diaphragm. And that actually reduces the motion significantly of the disease that needs to be treated. So absolutely, most institutions should have that mechanism, and you don't need to hold your breath to get SBRT effectively and safely.
Another question that really comes up a lot with patients, and a question that was asked during your talk, is if radiation increases toxicities for patients that are on targeted therapy, and what do we know about the safety of combining the two?
I think, I mean, all of these studies that have been completed or, moving forward in the right direction have asked that question very critically, because as we know, some of the TKIs can increase the risk of pneumonitis, and then you add that radiation to that. But the safety profiles so far have been pretty positive in the sense that there hasn't been some overwhelming signal that would make us very concerned about using them together. I still hold the TKIs a few days before the SBRT till a few days after, abundance of caution. Remember, the lesions that we're treating with SBRT are relatively small lesions. We should be able to protect the rest of your lungs. So far, I think the signals are positive about being able to use both together without significant toxicity.
Yeah, I would agree with that too. We at Emory, we presented our experience of osimertinib with SBRT to mainly lung and bone lesions a couple years ago at World Lung, and we had pretty low toxicities. So I definitely agree with you on that point. I generally, when I'm seeing these patients, will call the medical oncologist and we'll have a discussion about whether or not the medical oncologist is comfortable with the hold on the TKI. And many times, the medical oncologists I work with are not comfortable with stopping the TKI for radiation. So, more often than not, I am treating patients with the TKI on board. But I think the important thing from the patient point of view is to make sure that your doctors are communicating and that there's a plan for what you're going to do with the drug therapy while you're getting radiation, and everybody's on board and is in agreement with what's happening. Because sometimes, particularly if you are getting radiation at a different facility from where your medical oncologist is, the communication may not always be happening. And I think that it's just an important point as a patient that you can advocate for yourself and just make sure that your doctors are talking to each other and are on the same page when it comes to how you're taking your targeted therapy and if you're holding it during radiation. Do we have any comments on that from our medical oncologists on the panel?
I really agree with the points that have been made by both of you, Dr. Iyengar and Dr. Higgins. Unfortunately, there's no one universal approach that we take in terms of the overlap between the TKI and the radiation. In Boston, generally, our practice brief, where you don't have to worry as much about the flare of disease with the holding of the TKI. The discussion becomes much harder when the radiation has to be of a prolonged course, right? If someone's requiring 3 weeks or longer of a radiation course, then there really has to be a careful weighing of how much active disease burden is there at the present time, and then what area is being irradiated in terms of potential overlapping toxicities. Certainly with certain TKIs, for example, with osimertinib, where we know that there's a pretty significant risk of pneumonitis. If there's anywhere in proximity to the lung that's being irradiated, we will definitely not overlap. Similarly with bowels, if we're worrying about diarrhea and bowel toxicities, then we will not overlap. And then with the brain, we're very careful as well. With a lot of the CNS penetrant TKIs, we worry about increased risk of radionecrosis. And so we generally try to overlap, overlap the Dr. Royce, Dr. Desai, do you have any thoughts?
Yeah, I would agree with that approach. I mean, I think, the last thing you also want to do is get in a scenario where then you do have a significant toxicity, and then you might have to hold therapy even longer because you ran into a toxicity, rather than knowing that by and large, if you restart this therapy, you should be able to get the response back. And, I don't think there's any data to suggest that holding the therapy will lead to increased risk of resistance or anything like that. So I think it's always better to err on the side of safety, especially when you really want to engender a long-term response with less toxicity.
Yeah, I completely agree. And I think I agree. My practice is sort of consistent with what Dr. Anger pointed out in terms of sort of peri-radiotherapy period, discontinuation or holding of TKI. I think that's, again, out of abundance of caution.
And I will also mention one of the things we can do from the radiation point of view is we can alter the schedule to try to make the amount of time where the TKI is held as short as possible. So that's another thing that you can sort of ask your radiation oncologist if that's possible, just to, instead of giving SBRT every other day, can you give it every day, for example? And that's a way that we can, I think, optimize our outcomes potentially. And so what about the question about our patients that have locally advanced non-small cell lung cancer and have driver mutations and receive chemotherapy and radiation? I know in our practice, we are not generally giving these patients immunotherapy, but I wanted to ask the panel, what are you guys doing in terms of targeted therapy for patients that you've identified to have a driver mutation?
Yeah, so I think, as I alluded to, this is an excellent question. I think it depends a little bit on the driver mutation, what therapies we have available. I think when you talk about classical EGFR alterations, ALK fusions, where you have really an excellent CNS penetrant oral targeted agent with an acceptable safety profile, I see very little harm and downsides to administering the targeted therapy after chemoradiation. We know that the risk of recurrence in these patients is even higher, typically, than even the stage 3 patients that have resected. They typically have a more advanced disease. And I think immunotherapy is very difficult to consider in that scenario, because if someone progresses on durvalumab immunotherapy and you then want to start the targeted agent, you start to wrestle with the toxicity. Do I need to hold out a little longer? What agent do I start? Do I dose reduce? And I think it's best to avoid those questions if you don't think that immunotherapy is likely to have a significant benefit. But again, not all mutations are created equally. I think KRAS, for example, we know there's benefit to immunotherapy. And then there's some mutation subtypes where they may not benefit from immunotherapy, but we just don't have a great agent that we can give long-term. You look at EGFR exon 20 with amivantamab or mobocertinib, or even some of the MET targeted agents, where you just worry about the ability for patients to take these agents for, 1, 2, 3 years or indefinite in that scenario.
Yeah, I completely agree with what Dr. Ruiz mentioned. I think it really depends on the mutation that we're talking about. And again, I think it's a very, I think it's something which needs a lot of discussion with the patient, because remember, I mean, that even in the EGFR classical EGFR mutation setting, we know that durvalumab may not be as good, but we don't know that osimertinib is the best, so to speak. I mean, it's the best we have, but we don't have really good phase 3 data. So again, with those caveats, I think there's a good amount of patient discussion that goes into that. But I agree with Dr. Rose, especially in some of these newer mutations where we have decent data, where there are second line approved agents. I don't think I would feel comfortable sort of starting them just post chemoradiation, given that, okay, immunotherapy is probably not going to be good enough.
We had another question in the chat that was asking about biomarker testing for early stage non-small cell lung cancer. And is it something that is routinely done now, given the recent data that has come out with the use of targeted therapy in early stage disease? So I guess just hearing from people and at their institutions, what happens for patients that have early stage non-small cell lung cancer in terms of biomarker testing?
Yeah, so I think at both. So I trained at Mayo, and we used to do, even for early stage, do biomarker testing. Now I'm transitioning to UAB. I think here also the practice is that, and as you mentioned, Dr. Higgins, as more and more data come out for the perioperative immunotherapy setting, which some of which Dr. Rose touched upon as well, I think it's important to test, because some of these studies did exclude EGFR and ALK mutated disease, so may not be directly translatable to that. So definitely testing, pretty much all of our patients, early stage, advanced stage, except for possibly just stage 1, with the biomarker testing.
Yeah, and I'll say it's absolutely critical, but it's an even more challenging environment because you're oftentimes dealing with a smaller biopsy sample. Perhaps a pulmonologist went in and did an FNA, a fine needle aspiration. So there's limited tissue. You want to know the histology, make sure it's not a small cell or some other different type of more aggressive lung cancer. And then, playing the waiting game and someone who you want to then go on to surgery, do you send that out for a full NGS and not enough tissue? Do you do a more limited panel? I know at our institution, we're starting to actually kind of revert a little bit and do some more limited panel testing to some of the more, actionable kind of limited alterations, so we can at least get those answers quickly, so we can try to make, a decision, tumor-informed decision that still allows for a curative intent treatment approach.
I mean, I'm just going to add that, yeah, I mean, I think as patients, patient advocates, family members, it's and physicians and teams, it's on all of us to really push hard to make sure that the testing is done for early stage disease. It's relevant for disease that's resectable. I imagine very soon it's going to be relevant for patients who receive SBRT for early stage disease, for instance, because there may be some SBRT adjuvant immunotherapy trials that become mainstream. And if you have a targetable mutation, it may not be ideal for you to receive immunotherapy in the adjuvant setting. And so there are a lot of reasons why, for all indications, early stage disease, we should really push to get some form of testing up front.
And then what do you guys think is happening in the community setting? I know probably at your institutions, molecular testing is happening on all non-small cell lung cancer patients, but bridging the gap and making, we're having consistent processes for patients that are treated everywhere is, I think, a really important point. And I just wanted to ask about what your experience is with patients that are perhaps coming in from having been consulted on in a community setting and what you're seeing.
Yeah, I mean, I would say it's been variable, but I think it's getting more and more to the point that we are seeing more and more patients being tested in early stage setting, again, because some of the pivotal trials for perioperative immunotherapy did sort of exclude certain patient or certain subgroups of genomic altered patient, non-small cell lung cancer patients. I think the other important point we have to mention is, it's important to test, because if we test and we identify, then we can offer clinical trials. I mean, Dr. Rose mentioned a few in the perioperative space with, tyrosine kinase inhibitors. So again, I think testing there also becomes important to be able to offer these options for clinical trials.
And there was also a question in the chat asking about more rare mutations, RET, for example, if there were any opportunities for trials for early stage patients to receive targeted therapy that have more rare targetable mutations.
Yeah, so there are studies ongoing. For example, with RET, the Libretto studies. That's kind of the generic name of these RET targeted therapies. With I believe that's with selpercatinib, given either before surgery or after surgery. But again, I think this is a scenario where if we don't have data, but we know we have highly effective targeted agents that have good CNS penetration and are relatively well tolerated, I think that's where you can really have a discussion with your provider of, is an off-label use of this appropriate in this scenario? I mean, I think the RET targeted agents do check a lot of those boxes, again, of an agent that is effective with good penetration into the brain and that's reasonably well tolerated, where I think an approach similar to osimertinib after surgery, similar to ADAURA, can be mirrored for these patients.
I think the two key messages of several others that all of the attendees are hearing today from all of you speakers is that, one, you have to make sure all the biomarker testing has been performed, right? Because that is the starting point for all of our discussions today. And second, that in the postoperative setting or perioperative setting, we not to just default to immunotherapy. Even if, for example, PD-L1 biomarker level is high for these certain targetable genomic subsets of lung cancer, just defaulting to pembrolizumab or atezolizumab after concurrent approval for these agents. And so those two things I would really encourage all of the attendees to remember is making sure all the genotyping and biomarker testing has been done, and then making sure we are not just defaulting to immunotherapy depending on the specific type of lung cancer that you have.
That's a great message. There was one other question in the chat that was referring to squamous cell carcinomas, asking if biomarker testing should be done on patients that have squamous cell lung cancer.
Yes, so I think traditionally, obviously, we've thought of these genetic alterations occur more commonly in non-squamous adenocarcinoma, subset of non-small cell lung cancer, which is obviously true. But I think increasingly, even in high smoking population, we are able to identify certain alterations to which we may have targeted therapies. I think if you look at the NCCN guidelines, I don't think they actually differentiate between non-squamous and squamous in terms of testing paradigms. So even though it's probably going to be less frequent for us to find, and I think in a particular situation where we have a high smoking population where we're not able to get tissue or ctDNA, to identify for these biomarkers in those sort of special situations, it's okay to go ahead with treatment if we are able to identify other biomarkers with PD-L1. But I think in most cases, I would say, regardless of squamous or non-squamous, I think biomarker testing will be very helpful and indicated.
And I'll add too that I think smoking status does matter here as well. Now we know that patients who have never smoked who get squamous lung cancer, that's a very rare population. But we reported on some data looking at the CARIS Alliance. We reported on some data at ESMO that showed in never smokers, there is actually an increased enrichment for some of these alterations like EGFR and MET in squamous lung cancer as well. So I would agree with Dr. Desai. I would do genomic profiling on all patients regardless of histology, but certain factors like smoking status might kind of affect the pretest probability of seeing one of these driver alterations.
And then from the patient point of view, when you develop resistance on a targeted therapy, what should they be asking their doctors? What are the important things that the patient should be aware of when their cancer starts to progress? Can you offer any pieces of advice when a patient reaches this point in their journey?
I can start us off. I think some of the key questions to ask are, first of all, where is the cancer progression happening? So we really care about the location and also the pattern of progression. Dr. Iyengar is touching upon whether the number of sites that are changing versus diffusely multiple sites throughout the body greatly impacts how we think about a potential role for local therapy like radiation or ablation or sometimes even surgery versus switching the targeted therapy an option. So that's the first important question is, where is the progression occurring and what's the pattern of progression? And secondly, if we're at a point where we are having to switch the actual medication, then what are the options and how will we decide which one is most suitable for my specific cancer? Really trying to personalize the subsequent therapy as much as possible. And there, it can be helpful to consider repeat biopsy, although there can be variabilities in access and insurance coverage there as well. Then Dr. Desai, what's your practice and what do you discuss kind of in terms of broad strokes when someone is progressing on targeted therapy?
Sure. Yeah. I think first and foremost, too, in addition to kind of whether this is a limited progression or a more advanced progression, is also then discussing biopsy because we know that sometimes the way that the cancer can kind of outsmart the treatment might be in a way that we have another therapy that's available in an off-label scenario. I think we all have seen this with MET alterations or other fusions where we might be able to add an approved targeted treatment to our arsenal to extend the benefit. Also, we know that the cancer can sometimes look different. So if it's an adenocarcinoma, it might transform into a more aggressive small cell lung cancer. And so I think biopsy is super important there and is important in informing the treatment selection and whether there's something approved. Do we add in chemo or do we look for a clinical trial option?
Yeah, I completely agree with everything that's been said, including the fact I think it's most important to identify whether this is sort of what we call oligoprogression or progression at a limited number of metastatic sites where we can collaborate with our radiation oncologists or surgical colleagues to see whether there is any local therapy that we can offer while continuing the systemic therapy that has hopefully worked, for a period of months to years. But I think when there is systemic progression, as Dr. Rose mentioned, I would agree that, tissue biopsy is important specifically to look at whether the cancer has sort of changed its colors or transformed into a different histology where the treatment paradigm may be different, more focused on chemotherapy if it's small cell lung cancer, for example. And then I think when tissue biopsy is not feasible, I think I'm increasingly incorporating liquid biopsy in this particular instances where I'm trying to plan systemic therapy in second line or subsequent lines based on resistance, the mechanism of resistance. Particularly for EGFR and ALK, there are, and probably other, genetic alterations as well. There are newer generation TKIs that are coming up, which may be more effective against, the common resistance mechanisms. For example, with osimertinib, the C797S, there are other newer next generation, fourth generation TKIs that are currently in clinical trials, which may be more effective in those cases. So again, very important if we can, again, from a biomarker testing standpoint, even in the relapsed, setting, again, for identification of the actual resistance mechanism, as well as enrollment in clinical trials to really target. I think of this as like precision oncology 2.0, like sort of doing it all over again to make sure that we are really targeting the cancer where it's being resistant to the current treatments.
One other thing I will add is we also looked at the pace of the cancer changing. So we ask, is the progression causing symptoms or is it very kind of slow, what we call indolent? Some of the lung nodules may be growing by 1 or 2 millimeters each scan, and it's really not causing any symptoms. In those scenarios, it's changing therapy right away. If you're having a great quality of life, no side effects from the medication, and it's by and large doing a really good job. The medication is by and large doing a good job controlling cancer, then sometimes the doctor may recommend continuing to watch for now and seeing what the next scan shows before we rush to doing a biopsy or changing the medication. So you may hear about that approach as well from the doctors.
Those are all very good points. I have two questions now for Dr. Iyengar. One of them is asking about the role of surgery for local therapy for patients that have oligoprogression on TKI. And then the second is regarding the use of radiofrequency ablation specifically for adrenal nodules and if that is an effective local therapy. So if you could comment on both of those.
Sure. I think surgery is a very reasonable approach in treating oligoprogressive lesions that are amenable to surgery. Most places, we really should take a multidisciplinary approach to talk about what is the right modalities. We shouldn't jump straight into radiation. We shouldn't jump straight into surgery. We should not even consider local therapy unless it's a multidisciplinary decision. I think that's really the best approach. But surgery is definitely on the table. A number of these studies incorporated surgery. It just happens to be that it was used about 20-25% of the time in some of the studies, and radiation about 70 to 80% of the time. But it's a very reasonable approach. Isolated lesion in the lungs, you can have a segmentectomy, or you don't need a necessarily lobectomy. I think it could be very good. Now, with respect to radiofrequency ablation, I saw the question, and part of the rationale for the question was that the patient wanted to stay on his or her TKI and was worried and was thinking that ablation would allow them to do so with less toxicity. As Dr. Higgins pointed out, we can get patients in for radiation in and out extremely quickly these days. We can even do one fraction SBRT regimens that would provide some durable outcome in the adrenals. We could do 3 fraction regimens. We could do things very quickly. And so for those institutions that choose to put the patients off the TKI for a few days, this really ends up being a few days. And what Dr. Royce mentioned, there's really limited data to suggest that the disease is going to become resistant within that short time frame that they're off the TKI. And then the final thing I'm going to say is that there's just not a lot of randomized data, even early, small, randomized phase 2 type of data of any kind, let alone very rigorous prospective collected data that suggests that ablation is a durable treatment for metastatic disease. When do I use ablation? I use ablation if I've treated a patient with SBRT. There happens to be an in-field failure, unfortunately, which is rare, and then I can't radiate again. Then I refer the patients for ablation.
That's exactly how I use radiofrequency ablation as well. So we tend to go the SBRT route and then use it for salvage if we need to. I have a very good question next. It's kind of the $1 million question that I want to pose to the panel. Somebody asks, what could patients do to help close the biomarker testing gap?
Yeah, it is a very important question. And I think, as I mentioned, a lot of this comes down to being aware, like awareness of, the biomarker testing, being able to, I think Dr. Rose's slides had ask and advocate. And I think that's very important. As a patient, you want to, at every stage of where your cancer treatment is being discussed or sort of changed, you want to ask your oncologist that do I need to repeat biomarker testing? What are we basing the decision on, to really trying to understand, what their biomarker testing is from a cancer standpoint. What does their cancer sort of genetically look like? I know obviously we rely a lot on electronic health records. I advise my patients, and I usually print out their biomarker testing results and have them keep a copy as a document, because when they go from one healthcare system to another, this is sort of the thing that's sort of lost in translation, buried in fax machines and whatnot. And so I think it's very important if, for them to be aware, sort of really have that document when they are trying to seek a second opinion or something, to actually, have that to be able to show and get a decent opinion on what the next step would be, from each oncologist. And I think from a caregiver standpoint, again, I think it's important to understand what your loved one has in terms of biomarker testing, what is needed, and again, being there in the clinic, asking questions, noting down the questions you want to ask for your treating physician, as to how are we going to sort of decide the next line of treatment, or this particular line of treatment, why are we doing this? Can we do something more targeted? I think those are the questions really to ask for.
Dr. Lin or Dr. Roos, do you have anything to add to that? I think that was a great answer, Dr. Desai, to a hard question.
Yeah, I agree wholeheartedly. I think I already see patients making a difference, actually. I have seen second opinions where patients come and tell me, I had heard from a friend of mine that this absolutely needs to be tested for. And so I asked about it and it was done. And this is what we found. I think sharing your stories can be really powerful in terms of how the biomarker test, what it's led to in terms of treatment options. In the patient advocacy groups, that can be really helpful as well. So I think many of you are already doing to kind of spread the awareness, and continuing to do so will be very important.
Absolutely. We have another kind of general question that just came through the chat. What are we learning about prevention and causes of lung cancer? Does the US have a higher incidence, I guess, to other regions in the world? One of the oh, sorry, go ahead.
No, I was just going to mention, I mean, we are obviously, there's a lot of research being conducted in terms of like the causes of lung cancer. I mean, just a few months ago, there were a series of papers from the UK about air pollution and how air pollutants can lead to lung cancer, even in patients who are never smokers. So I think there's obviously ongoing research. We're learning a lot in terms of what kind of particulate matter may be responsible for lung cancer. In terms of prevention, I mean, there are increasingly, I mean, at least in the literature, I'm seeing increasingly number of different models we are using to identify. There's AI-based, CT lung cancer screening models to see whether we can, really predict which lung nodules may develop in the cancer. So there's a lot of ongoing research, but I think just in general, etiology prevention, sort of this epidemiological research is very difficult just because it's not, as simple in the terms of understanding that you have a cancer, you treat it, it shrinks, then it's working, So I think that's why some of the roadblocks to actually our understanding, but it still has gone a long way since we started.
I think another interesting kind of side aspect to that question is, can we actually screen more patients for lung cancer? Are our screening guidelines really encompassing the maximum number of patients that should be screened for lung cancer? And for example, Dr. Elaine Shum at NYU is leading a very interesting study at looking at lung cancer screening for young Asian female never smokers, because we do know that this is a population that might be at greater risk for some of these driver mutation lung cancers. Now, that's not everybody, obviously, and we, at the end of the day, can't screen everybody for lung cancer, but I think asking what populations warrant additional screening so we can detect these cancers earlier and cure more of them is also an important aspect to that question.
Progress is being made slowly but surely, and I think what we can do is, what patients can do is for all the people that are former smokers or active smokers, just really advocate that they ask their PCPs to order a lung cancer screening study. It's still so underutilized in the United States, even though there's great data to support lung cancer screening, and it's something that is low-hanging fruit that I think everybody that is a lung cancer survivor can really help us with by just spreading the word to your community, your circle, your network, your family, your friends. And hopefully we can see that improve over time. I do have a question for Dr. Iyengar related to the role of specifically CyberKnife in somebody that has a stage 4 lung cancer with an exon 20 EGFR mutation. So could you speak, I guess, generally about the type of SBRT, the platform that's being used, and if that is any different, if it's CyberKnife versus Gamma Knife or what have you.
They're absolutely right, Dr. Higgins. There's multiple platforms that can deliver SBRT. For instance, in the brain, it's called SRS, but it's the same concept. And there's a Gamma Knife type of machine, and there's traditional LINAC-based approaches to treat brain mets. Below the neck or from the neck down, you can use multiple different platforms as well. CyberKnife is a platform. It's been effectively utilized by a number of investigators and physicians. It has a little bit more unique aspect that you place what we call a fiducial in the lesion, which is detectable by the machine, which can then use that to monitor movement and then deliver radiation specifically to that fiducial marked area of disease. So it's highly conformal, meaning it's highly localized. It's specific to the tumor. You could probably use reduced margins a little bit to try to deliver the radiation. But in general, I would say that all of the platforms work quite well and effectively well to deliver SBRT type of radiation doses and fractionations to the disease. We would not necessarily, whether it's specific type of mutation, each specific type of EGFR mutation at this stage doesn't drive use of a specific platform or a specific machine, but they're all pretty solid, I think.
Thank you for that. And we're coming to the end of our panel discussion, but one question just came in that I want to pose to everyone, and I think it's a great question. There are a lot of patients now that have been on TKIs for a long time, long haulers. Do we know what is enabling these patient successes? Why are they not developing resistance? What's known about these outliers that are doing so well on TKIs for many, many years? Dr. Lin?
So this is an area of a lot of research that's happening right now. I agree that that is a very important question. We don't answer quite yet. We know that in certain subsets of lung cancer, such as, for example, EGFR lung cancer, there's data to suggest that certain co-mutations can correlate with shorter duration on a TKI targeted therapy, or P53 mutation is a well-known one where when there's a co-mutation in P53 with these drivers like EGFR mutation or ALK fusion, retrospective studies are showing that patients who do have co-mutations can have sometimes shorter time to cancer progression. But I think we're really touching at the tip of the iceberg right now, and there's still a lot more work to be done looking at for fusions, different fusion variants and impact on outcomes, total mutational neoantigen landscape, and whether that correlates with outcomes. And all of that research is still ongoing.
And actually, one other question just came in, and maybe we can end with this because I think it's a very practical one. When you are seeing a patient and you get PD-L1 results back and it's high, but you don't have the results of NGS, what is your approach for initiating therapy for these patients that have metastatic disease?
Yeah, so I think that's an important question, one that we still see as second opinions. I think when we're on talks with other physicians in the community, I think this point is still raised. And I think it's important, you still have to wait for the molecular testing. You can't go off of PD-L1 alone. We know that in these driver patients, patients with drivers, especially EGFR, that even if there's a high PD-L1, that does not indicate a potential ability to respond to immunotherapy. We've seen that proven in clinical trials. So, I think you can still look at that and say, all right, maybe that will help inform the decision when the rest of the results come back, but absolutely you should not act off of PD-L1 alone.
Yeah, I completely agree with that.
Great.
I am on the same page as well. I think the question becomes whether you have to at least get a cycle of chemotherapy in while the genotyping is pending versus being able to sit still and anxiously wait. where that decision has to be made. We really look at the symptom, the burden of cancer on the imaging, and take all of that into consideration in guiding that treatment decision making.
Well, this was a really interesting panel, and I have to say our patients posed very interesting questions, and you all are extremely educated on this disease, and I think that's amazing, and please keep it up and keep pushing us to move faster and make discoveries so that we can, eventually make lung cancer a curable disease for everyone. So thank you guys very much.
Thank you so much, Dr. Higgins, for a wonderful question. It was a really rich Q&A. Thank you. So everyone in the audience, we are now going to be breaking for lunch. Please return at 12:30 p.m. Eastern Time, 9:30 a.m. Pacific Time. This will be for breakout session. As a guidance, the main stage will be R and KRAS, and then the secondary stage will have the ALK, ROS1, RET, and other rare fusions. So please come back in just about 30 minutes and we'll continue. Thank you very much.